right, you guys. So we are going to jump into our next disease process, and this is pulmonary edema. And we have to understand what pulmonary edema is, what kind of is the downstream effects from pulmonary edema, and what actually causes it, or what's the etiology from pulmonary edema. Remember, if you look at this, this looks like there is a bunch of fluid. There's a bunch of fluid sitting here in the alveoli. So you can see a bunch of fluid that is pouring into those alveoli. And the question is, how does it get there? And we're going to talk about that right now. So when we look at this, when we look at pulmonary edema, it is an excessive movement of fluid from the pulmonary vasculature into the extravascular system, or the interstitial space, and into the alveoli, or the air sacs of the lungs. So we've got fluid that is moving from the pulmonary capillaries and then escaping those and moving into the interstitial space and into the alveoli, and it can even fill the alveoli to move into the bronchioles and the bronchi. So this is fluid that is seeping into, your book talks about fluid seepage into or out of the pulmonary capillaries. So when we look at this, the fluid may move into that interstitial space and the alveoli and continue to build up depending on how severe the pulmonary edema is. So when you get that increase in volume in the alveoli, what ends up happening is you get alveolar swelling. So there's a thickening of the alveolar wall, and there's a thickening or a widening between the interstitial space and that AC membrane. The alveolar capillary membrane starts to widen. There's a bigger gradient there. There's interstitial swelling. So the movement of oxygen tends to be a lot slower because it has more obstructions or more fluid to kind of get through. And the problem is oxygen does not swim. Oxygen does not swim at all. So you've got the fluid that's in the alveoli, you've got the alveolar walls that are starting to swell, and you've got this interstitium, or this interstitial space, that is filling with fluid as well. So what happens when you have all of that fluid in the alveoli? Well, one, the oxygen can't swim through that, so it's not going to get into the pulmonary capillaries, not going to get into the bloodstream attached to the hemoglobin and then circulate around. But what else happens to the, let's talk about the pneumocytes, right? So what happens to the pneumocytes if I have a bunch of fluid that is sitting on the alveolar wall? Well, what happens is that fluid starts to wash off that surfactant. And what does surfactant do again? What it does is it helps maintain that alveoli open. It reduces the surface tension. The more surface tension that I have, the more I want to collapse on myself. So by adding or having all of this extra pulmonary edema in the alveolar walls, it's not only creating this diffusion defect, but it's also washing out that pulmonary surfactant, which will increase the surface tension, and you have alveoli that want to collapse on themselves. So not only do you have all of this fluid that is sitting in the alveoli, but you have alveoli that want to start to collapse. So that makes it a real big problem when you want to try to open up those alveoli to breathe. So you start to see, you get that alveolar collapse. You get more fluid that wants to accumulate. And then what is our system that is kind of our trash removal? That's right, the lymphatic system. So when we have the lymphatics that are now overwhelmed, they have to dilate, and you get what's called lymphatic vessel widening or dilation. So if I increase the diameter of the lymphatic vessels, what happens to flow? This goes back to Poiseuille's law, right? If I increase the diameter, if I increase the radius of a tube, the lymphatics are a tube. If I increase the lymphatics, if I go from this size to this size, what happens to flow? Flow increases, pressure decreases. So we see an increase in lymphatic flow. Now, when we have, and this is one of the telltale signs, so I want you to circle, I want you to highlight, I want you to put a big star around these white, pink, frothy secretions. So what ends up happening is you have all of this fluid that is sitting in those air sacs, and you get air that's moving in and out of that. Do you ever remember being a kid and making spit bubbles, right? So you put a bunch of saliva in your mouth and you build this big old saliva bubbles, right? That's essentially what's happening inside your lungs. You create these frothy secretions. It is an increase in secretion, and there's a bunch of airflow moving in and out, which will cause frothy secretions. Now, the way we get these pink secretions is if we start to add a little bit of red blood cells. We add red blood cells to the white secretions, and white plus red will equal the pink frothy secretions. So those are some big telltale signs. This is kind of the patho of pulmonary edema. Some of the pathologic changes that we see, or structural changes that we see, is you start to get interstitial edema. So you get an increase in fluid. You get an increase in fluid in the air sacs. The alveoli start to flood with all of that extra fluid. You get an increase in surface tension as a result of the decrease in surfactant, leading to alveolar shrinkage, or what we call atelectasis. And then your telltale sign with those are the white or pink frothy. Go ahead and write in frothy right there, frothy secretions. Your clinical manifestations, you're going to end up with atelectasis. You'll have an increase in membrane thickness and excessive bronchial secretion. So all of those will lead to what you will see in your signs and symptoms. The epidemiology, the text says that cardiac conditions are still the leading cause of death in the United States. So we've got to do everything that we possibly can as respiratory therapists to educate our loved ones and those around us and our patients on the hazards and the complications of heart conditions. Heart disease, ultimately, over 650,000 Americans succumb to heart disease every single year. And when we look at the statistics in America, about every 40 seconds there is somebody having a heart attack. So we have a lot of work to do when it comes to taking care of our hearts and patients with heart conditions. Some of the risk factors that we look at, now we're going to widen this out and we're going to look at big risk factors, but this is kind of nailing down some specifics. But when you have patients that have high blood pressure that is greater than 140/90, or patients that are on any hypertensives. So either one of those, patients that have a high blood pressure of 140/90, or you have patients that are on anti-hypertensive agents. The other thing is we need to look at our cholesterol. Your LDL, this is your good cholesterol. So your good fats, your nuts, your avocados, those types of things. When we look at the HDL, this is our bad cholesterol. This is the bad cholesterol that we don't want to have. So if our total cholesterol is greater than 150 to 200 milligrams per deciliter, that increases your risk for heart conditions. When we look at the triglycerides, if our triglycerides are greater than 200 to 300, that increases our risk to heart conditions as well. So when we look at the overall risk factors with pulmonary edema, what we're looking at is age specific. So when we look at the men, if they have an age greater than 45, their risk goes up. If we have women that are greater than 55, their risk goes up. when we have patients who are smokers or have a history of smoking, especially cigarettes. Now, there's not a lot of data, and I need to look into this a little bit more, but perhaps there's some data with vaping as well. So we need to look at that in the future. Diabetes type 1, type 2, obesity or overweight. When we look at an unhealthy diet, a lack of physical activity, alcohol in excess, whether you have obstructive sleep apnea or central sleep apnea. And this one will kind of always be there, is if there's a family history of heart conditions, then you are at an increased risk for heart conditions as well. So a couple of things that we have to look at is the left ventricular heart failure. So we're looking at the left side of the heart. This is the big portion of the heart that circulates blood from the heart all the way through systemic circulation, from the top of your head to the tips of your toes out to your fingers. That left ventricle moves blood all the way around your entire body. So when we look at left ventricular heart failure, this is the left ventricle is unable to pump out enough blood during each ventricular contraction. So if I'm not getting all of that blood out, it's not circulating all the way through, it's going to start to back up. If it backs up, it's going to go into the left atrium, through the pulmonary veins, back into the lungs or the pulmonary capillaries, which then has the opportunity to spill over into the alveoli. So part of what we look at is looking at the left ventricular ejection fraction. Remember, we've looked at ejection fraction before, and this is the amount of blood that leaves the ventricle compared to the amount of blood that came in. When we look at normal values, so when we look at normal values for ejection fraction, the normal value is 55 to 70%. So the amount of volume that I get out compared to the amount of volume that comes into that ventricle should be 55 to 70%. Now, when that value drops below 40%, that is an indicator to confirm heart failure. If that ejection fraction or the EF, if the EF falls below 35%, this can actually be life-threatening and it can lead to arrhythmias. So how do we get the ejection fraction? Well, this is done through an echocardiogram. So it's a way, it's an ultrasound, it's a sonogram of the heart, and they're able to measure the volume coming in and the volume that escapes after each contraction. So this looks at and is reflective of the left ventricular systolic cardiac contractility. So we're looking at the left ventricular systolic contraction. So what is systolic? Remember, that is the contraction. So it's almost like these words back to back is a duplication or kind of redundant, but we're looking at the left ventricular contraction. And when we look at causes of poor ventricular function, this can be diastolic dysfunction. This can be an increase in the ventricular stiffness, and it can also be an impaired myocardial relaxation. So if I have a ventricle that is too rigid to open up, then it won't allow fluid into it. If I have an inability to relax so that that preload can fill that ventricle, then that would cause a poor ventricular function. Other kind of causes of a poor EF would be arrhythmias. So if you have ventricles that are not contracting on time with the atria, then that would lead to kind of a misflow of what's happening, and that would lead to a decrease in that ventricular function. So normal values, just to cover it again, normal EF values, the normal is 55 to 70%. Heart failure, to confirm heart failure, is going to be less than 40%, and life-threatening is less than 35%. So when we get down to that 35%, we have an increase in the likelihood of arrhythmias. So low values increase the blood pressure in the pulmonary veins and the pulmonary capillaries. So if I increase the pressure there, it will push the fluid from the capillaries into the alveoli, and we end up with what's called transudate. Transudate is a type of fluid that accumulates in the body cavity, and we will talk about the specifics of what transudate is when we get into pleural effusions. We'll kind of break down what transudate is.